emerged, and now everything has changed. So let's focus on that. First of all, how worried should we be about Omicron?
Well, how worried should we be? We need to be prepared and cautious. This is something we've been saying from the beginning of the pandemic. Not panic, because we're in a different situation today than we were at the beginning of 2020. We have tools, we know what to do, we know what works. And so this was something that we had expected, that new variants would emerge. We've been through rounds of other variants. And so it is something to worry about. Certainly, we didn't want to see another variant emerge and spread around the world at this stage of the pandemic. Certainly not what we wanted, but we're not entirely surprised, and I think we're much better prepared to handle it.
How contagious is it? Do you have new information about its transmissibility?
So let me say that, first of all, we owe huge thanks to the researchers and scientists and doctors from South Africa who've been updating us and working night and day to provide as much information as possible. From the early reports that we have, starting with the Gauteng province where it was first observed and then across the different provinces of South Africa, we do think it is quite infectious, quite transmissible, because South Africa has been reporting a very rapid increase in the number of cases. In fact, they've been doubling every day, and that suggests that this virus is highly transmissible. How much more transmissible than Delta, it's hard to say at this point of time, but it is a very transmissible variant. That's what it appears.
Experts in the European Union, in Australia, are already predicting that Omicron will become the dominant variant within a few months. Are they right?
It is possible that it could become the dominant variant. Now, Delta, let's remember, Delta currently accounts for 99% of infections around the world, according to the GISAID, the database of whole genome sequences. This variant would have to be much more transmissible than Delta to outcompete and become the dominant variant worldwide. It is possible that it could happen, but I think it's impossible to predict. And in terms of numbers, I think we should now prepare to not let the numbers surge. That's what we should do. Knowing that this could happen, we need to put in place measures to prevent those huge surges that then overwhelm health systems.
And what about its severity? We hear reports that usually cause mild or no symptoms at all. Can we assume then that it's milder than Delta, or is it too early to say?
Again, it's very early days. It's been only 1 week since WHO classified it as a variant of concern, and a couple of weeks since it was first observed in South Africa. Of course, now as countries are stepping up surveillance and sequencing, they're going to find more and more. We probably go back and look at their samples. But yes, the majority of cases reported so far have reported to be mild. Many of them have been vaccinated individuals, so that could be one reason why. But it's too early for us to conclude that this is a mild version. So everything that we're talking about today is going to be different next week when we know more about this variant. There's always a lag between infection progressing to severe disease. So as you know, when you see a surge of infections, it's 2 weeks later that you start seeing that surge in hospitalizations and deaths. So I think we need to wait. Let's hope it's milder, especially in those who are vaccinated or who have some previous natural immunity. But it's too early to conclude about the variant and its behavior as a whole.
As you said, many of the people that have been infected with Omicron had been vaccinated. Does that mean that the existing vaccines do not work against Omicron, or they provide less protection than against other variants?
Again, it's a very important question that needs to be answered. We need a lot more research. That's in a lot of those studies are ongoing. But what we do know, again, thanks to the South African epidemiologists who've looked at their data over a period of a year and a half to see how many reinfections. So reinfection is defined as somebody who's had a positive PCR test, and then 90 days elapses, and then you get another positive PCR. That's the definition of reinfection used in the study, and they have just posted some results to show that this variant, Omicron, seems to cause 3 times more reinfections than Beta and Delta, which was what South Africa experienced previously. And this is their 4th wave. So it does seem to be able to overcome some of the natural immunity that occurred from previous infections. Now, how much more is it? How much evasion of immunity does it do, especially against vaccines and against previous infection? We will have to wait and see. But let me just say that about vaccines, that firstly, the vaccines were developed essentially to modify disease, to prevent people from getting sick and dying. We know that they do that extremely well, that all of the currently used vaccines are highly, highly effective in preventing severe disease. With Delta, we found out that they don't prevent infection as efficiently, So it's possible that the Omicron variant is able to overcome and cause infections even in previously vaccinated people. We are seeing that now with a lot of previously vaccinated people who are the first few to be reported with Omicron. However, the fact that they're not getting sick, and again, we have to wait and see, but if they develop only mild illness, that means that the vaccines are still providing protection. And we hope that they will continue to provide protection because, immunity is a very broad, it's not just the antibodies in the blood. And so we hope that these vaccines have elicited enough of an immune response in the body to still protect against severe disease.
Still, it's very likely that we will need an upgraded version of the vaccines we are using at the moment because of Omicron. So do you think this will need to happen just to counter Omicron? And also, do you think this could become a yearly recurrence, like with flu, adapting the vaccine every year to a new strain or new variants?
So the WHO is preparing for all scenarios. And in fact, early in the pandemic last year, we set up several expert advisory groups, technical expert groups, to look at a couple of things. The first was really to track viral evolution. So we have, and that's the group that actually met last Friday and recommended that this be classified as a variant of concern. There's another group that makes policy on vaccines, SAGE, that's been around for a couple of decades now. And then we've set up a new group called the TAG, Technical Advisory Group on COVID Vaccine Composition, that is going to answer the question that you're asking. Will a new type of vaccine modified for Omicron be needed? We do not know at this point because, as we've seen with previous variants, the original vaccines that were developed with the Wuhan strain have actually provided pretty good protection against alpha, beta, alpha, as well as delta. Beta and gamma have, had much smaller populations affected. So it's possible that the same vaccines would work. It's possible that you might need an additional dose to boost that immune response. But it's also possible that you might need a modified vaccine that takes the gene sequence of the new variant, because as we've said, it's quite different from the previous ones with lots of more mutations in it. So this is work that's underway currently in many labs that are taking the stored blood, stored serum from people who've had vaccines before and looking to see the antibodies that they have can neutralize this new strain. So those studies will take another week or two for us to get, and that will start giving us an idea about whether this variant, how much does it escape the existing immunity. So we have this committee set up. I know that a lot of the vaccine developers are moving ahead, and it's good to be proactive and develop those vaccines just in case they're needed. But again, it's premature to conclude that we're going to need to modify all our vaccines.
Okay, so I guess it's premature also to say that we will need maybe a new vaccine every year.
Yes, exactly. So that's another question that is premature because obviously we're only a year into the use of vaccines, right? We started using them in December of 2020. And so as time goes on and we learn more about immune responses, some scientists believe that if you take a third dose, as an additional dose or a booster after a gap of months, then maybe that will be enough to protect you for the next couple of years, and you may not need these annual boosters. It's also possible that there may be some age groups, some vulnerable groups that need to be boosted, but not everyone in the population. And also, natural infection, we know also acts as a booster. So in many countries, people have had a lot of exposure to this, different strains of the virus, and have built up some natural immunity. So these are the questions actually we need answers to. And again, the WHO's R&D blueprint for epidemics is convening a global group next Monday to discuss what the priority research questions are and get more people around the world looking at these things.
Perhaps the group will also look into this issue, which I'm raising now, which is the fact that the vaccines we have at the moment target the spike protein in the virus. Do you think that perhaps research and new vaccines should target some other parts of the virus? Because we have seen with the Omicron that has a very different spike protein from other variants. And you think that perhaps this should have been done already now, actually?
No, that's a great question. And actually, there is work ongoing. There are a second generation of vaccines that are looking not only at the spike protein, but also at the nucleocapsid and other proteins. So I think there are vaccines under development, and we really want to encourage this second generation of vaccines that are targeting other antigens that also have other modes of delivery, like the nasal sprays, for example, that may induce better mucosal immunity than the vaccines that are given by shots. And there are also scientists working on what they call a pan-coronavirus vaccine. That would be really the best option, because that would be a vaccine that would be effective against all coronaviruses, or at least against the sarbecoviruses, SARS-1, MERS, and this particular virus. So there are different options. Ultimately, a pan-coronavirus vaccine, if we get one, will be very good. So we're also really working hard to support that further research and development, that it shouldn't stop just because we have a few vaccines in the market, but we need to continue to look for better options. And there could be also options of heterologous that work better. So you could have one type of vaccine platform followed by, let's say, an inhaled vaccine that could act as a booster, but also provide more mucosal immunity. So lots of very interesting questions.
It shouldn't focus only on the spike protein.
Yes, we must look broader than that.
Okay. Before Omicron appeared, there was kind of consensus among many experts, including, Anthony Fauci, that COVID-19 would transition next spring from a pandemic phase to an endemic disease. Do you agree with this forecast? And is that still valid now with Omicron?
So we know that the SARS-CoV-2 virus is going to become endemic, in the sense that we are not going to get rid of it in the near future. And so when you cannot eliminate or eradicate a virus, then essentially it's there to stay. It's with us, and it will cause disease. It will continue to cause death, just like other respiratory viruses that we have and that we experience year after year. Now, over a period of time, what will happen is that there'll be enough immunity in the population through vaccination, but also through all the natural exposure that's happened, to be able to reduce the number of people who get very ill and who die. And that's when you would say, well, it's no longer a huge public health emergency. It has become a disease that's with us. We know how to handle it. There will be some people who get ill every year. We have to take care of them. We're going to get more drugs, hopefully, to manage this. We might need booster shots for some people in the population who are very vulnerable. So again, this is likely to become a future scenario. When do we get there? We'll get there when we're able to achieve that level of immunity across the world, not just in a few countries, so that the transmission of the virus goes down. And most importantly, that we need to reduce the death rates. We still have 50,000 people a week dying of this virus, and that is not acceptable. So that's where we need to focus. Yeah.
But can you say by when you expect this to happen? To
We
the
hope
endemic phase to start?
You see, our goal is to vaccinate 70% or so of the population of each country by the middle of next year. That will cover almost all the vulnerable groups, right? The adults, particularly the elderly, the frontline workers, etc. Once you get into those levels of coverage, hopefully then you don't see this kind of devastating impact. Now the one big unknown here is what the virus does. We know what we need to do, we can do it, we can implement it, but the virus, the way it changes and the variants that arise, that is not something that we can predict or anyone can predict. So that's really the big unknown and puts us in a very difficult situation of predicting when we're going to get over this pandemic or when we're going to stop calling it a public health emergency and treat it as an endemic condition.
I'll move now to the origin of the new variant. Are we completely sure that it emerged in Southern Africa?
Not at all. In fact, it's because of the excellent genomic sequencing and surveillance and the very strategic use of genomic sequencing in South Africa that they were able to pick this up and inform the world. And we feel terrible that they've been punished for it. South Africa and the other countries around South Africa have been punished by the world. This is not what is expected at this stage when we understand how we can reduce risks of travel. Certainly, we need to be looking very carefully at reducing risks at all levels and putting in those measures that we know work, like PCR testing, insisting on masks, perhaps quarantining if there is a risk of infection, but not these ad hoc travel bans. So going back to your question, where did it originate from? We don't know. It could have originated anywhere. And it could be in countries which do not have enough sequencing, where essentially we are flying blind. And it's thanks to what happened in Gauteng and the fact that they picked it up so quickly that there was something unusual going on there and just zoomed in and did the sequencing that we found out and let the whole world know. And as you know, Netherlands then looked back and found even 10 days before South Africa announced that they had cases in the Netherlands. So I think it's going to take time. We may never know actually where it originated. But right now, what is important is that all countries have this expertise. We talk about equity for vaccines, but actually there's a huge inequity in diagnostics and even worse in genomic sequencing. And so 80% of the whole genome sequences today come from North America and Europe. And the African continent, Latin America are very poorly represented. So this doesn't allow us to really get a good view of what's going on everywhere. And so we need to step up that and help those countries also undertake surveillance. It requires both infrastructure, hardware, but also the training of manpower. And of course, it needs reagents. And, the scientists in South Africa have put out an appeal saying they can't do the work to inform the world about because there are no flights and they're not getting materials that they need for the lab.
Okay, you mentioned inequity, and this is my last question. The distribution of vaccines has been very unequal across the world. If Africa had received and administered more vaccines, is it fair to say that perhaps we would not have had Omicron?
Absolutely. And I think this is a message that Dr. Tedros, the Director General, has been from the beginning insisting. And it wasn't because the equity was only for ethical reasons. It was for exactly these scientific and epidemiological reasons. We knew that if you had parts of the world where the virus was just, propagating from person to person, transmitting, growing, that you would get ultimately new variants emerging. And this is going to keep happening again and again. So even today, it's not too late for us to look back and really sort out this once and for all and make sure that going forward, we do distribute both vaccines, but also diagnostics and drugs, because drugs are going to be needed to save people from getting sick in an equitable way. And this is why, ACT Accelerator and COVAX were set up in 2020, exactly to address this issue. But there's a clear relationship between inequity in access to vaccines and the development of variants.
Dr. Swaminathan, thank you.
Thank you very much.